Arthritis in Children, sponsored by Intercept. This session has been divided into two parts. The first part would be 3 cases which would be presented by fellows on the difficulty in management of juvenile idiopathic arthritis. I would like to welcome Dr. P.K. Sahu sir, Senior Pediatric Consultant at Jajpur, Dr. Aarti Behera ma'am, Professor and HOD Pediatrics at Sri Jagannath Medical College and Hospital, Puri, Odisha, Dr. Sibabrata Patnaik sir, Professor of Pediatric ICU, KIMS, Bhubaneswar, to kindly chair the session. I would like to introduce and invite Dr. Chandrika S Bhat ma'am, Rheumatologist at Rainbow Children's Hospital, Bangalore, to moderate the session.
Good morning. Now I call the moderator on this session, Dr. Chandrika S Bhat, Rainbow Children's Hospital, Bangalore, to please come to the stage and manage the session. Then the panelists are Dr. Jitendra Oswal, Bharatiya Vidyapit, Pune, Dr. Narendra Bagri, AIIMS, New Delhi, and Dr. Anushka Prabhudesai, SGP JIA, Lucknow. Dr. Chandrika S Bhat.
Thank you so much, sir, for the introduction. Good morning, everyone. So I think my panelists are on the stage. So Dr. Jitendra Oswal is from Bharati Vidyapit, Dr. Narendra Bagri from AIIMS, and Dr. Anushka Prabhudesai from SGPGI, Lucknow. So the outline, we'll have the case discussions presented by the fellows first. So I would like to call upon stage Dr. Arokya Raj. So once he completes the presentation, we'll open up the case for discussion.
Good morning, one and all. I am Dr. Arokya Raj, Rheumatology resident in Madras Medical College. Here's the case. A 10-month-old boy, firstborn of second-degree consanguineous marriage, came to our clinic on July last year with a low-grade fever for 3 days, followed by joint swelling noticed by mother for 2-week period. The history of presenting illness, the fever was very low-grade and continuous fever with no rash, chills or rigor or any other no localizing features. The joint swelling first noticed on the wrist, followed by knee and ankle joints. Mother noticed child having warmth over the joints and tenderness while moving the joints, and the child had irritability and limitation of the movements was noticed by parents. They denied any trauma or rhinorrhea or redness of eyes and any crying during micturition, diarrhea or skin lesions. The child had a recent vaccination, MR vaccination at primary health center 1 month back. No history of any TB or COVID contact during that period. This is the pedigree of the child. So the mother had 3 first trimester abortion and 1 second trimester and 1 IUD at 18 months of age. The mother was evaluated by her obstetrician. APS workup was done, which is negative, even though the mother was treated with prophylactic doses of heparin and low dose aspirin in the last 2 conception. There were no family history of any autoimmune diseases or inflammatory arthritis. On examination, the first visit, the child had dull looking and some pallor were noticed and insignificant cervical lymph nodes were noticed. The frontal pausing was present. The anthropometry was okay for the child. System on head to foot examination, oral cavity was normal, skin was normal, no organomegaly was noticed in the periabdominal examination. MSK examination shows swelling in both elbow, wrist and small joints of hand, knee and ankle joints. Tenderness was present in bilateral elbow and wrist. Investigations, this is the tabular column showing investigation. On first visit on July, the child had leukocytosis, anemia with a HP of 7.1 and thrombocytosis. ESR were raised, renal parameters and liver parameters were normal. LDH was normal, CRP was very high and ferritin was normal. And other cultures were negative, blood and urine culture were no growth, viral markers for HIV and VDRL test were non-reactive. X-ray hand shows diffuse osteopenia and wrist ultrasound and elbow ultrasound shows minimal synovial thickening noticed. Minimal effusion also noticed. And on August, the child readmitted for once again In the investigation shows the leukopenia leukocytosis was disappeared, but other anemia and thrombocytosis was persisting with the raised renal CRP values. Peripheral smear shows no atypical cells with a severe hypochromic and microcytic RBCs. This is the timeline of the child. The first admission at Institute of Child at Madras Medical College. So initial presentation as a inflammatory polyarthritis, initial probable diagnosis of infection or post-viral arthritis or malignancy was considered. After the initial workup, the child doesn't have any improvements, hence the child was referred to rheumatology clinic. So autoimmune workup, RF, ANA and ASO are done, which is all are negative, and the other supportive investigations ruled out infection and malignancy. Child was initially treated with antibiotic for short course with other supportive care. There is no improvement. So child was reviewed after after the baseline investigation. So there were no features of macrophage activation syndrome. Hence, the child was started on low dose dexamethasone. The child had significant improvement. So hence, the child was switched over to oral prednisolone. The child was discharged after 2 weeks period, but the child readmitted on 1 month back on August with the same arthritic flare. This time there is no fever or no rash, only joint swelling was noticed. The child was now added with methotrexate and advised for genetic test, whole exome sequencing, because the infantile onset of arthritis with multiple abortion in the mother. So on the follow of 18 months, the child had once again arthritic flare. This time due to the steroids were stopped by a local hospital for the vaccination time. The child during that visit, the child was restarted with a low dose of steroids with methotrexate was continued. This is the clinical picture showing first visit with a significant bilateral knee swelling. The last 2 images of wrist swelling, mostly showing swelling on the dorsal aspect. This is the results of a genetic test showing LACC1 mutation, which is an in-frame shift mutation, which is a pathogenic for this patient. So discussion. So juvenile idiopathic arthritis is a chronic and heterogeneous arthritis with unknown etiology and pathogenesis, mostly considered as a polygenic type. So LACC1 is a famine mutation, which is a crucial role in immune metabolic functions, mainly in inflammasome activation and reactive oxygen species production by macrophages, which is macrophages is polarized to two pro-inflammatory type. Hence, they have systemic manifestations such as JIA. The first case is reported in 2015. The LACC variant linked to JIA during that time, first time, and particularly in consanguineous families, which is about 94% family had a significant consanguinity, most of them from Middle East populations. Indian origin also reported till date. The female sex is the most commonly reported case. 7 different mutations in this gene reported. Most of them are polyarticular course of JA. So most common mutation is due to the missense mutation followed by loss of function mutation. Rare one is in-frame shift mutation, which is seen in this case. The management is similar to the other JAA case, but the remission is very poor in this group of patients. Mainly only 31.6% cases are till date reported to have remission. Remaining have poor to partial response. And the challenge is similar to other JAA case, but we have to follow up. So to conclude that, the LACC mutation is indeed rare, but it is reported, but the sporadic cases are very rarely reported. Most of them are familial cases, and we have to look for whole exome sequencing when they have present as an infantile onset, significant consanguineous marriage, and familial clustering of similar cases, and Middle East ethnicity is commonly reported. And recently, they have reported abortion and anemia with the LACC1 mutations. And the benefit of whole exome sequencing in the treatment still being explored, because we don't know how the child will behave in near future. Early diagnosis, whether going to alter the disease management or whether they will progress to another type of autoimmune disease, we don't know till.
Yeah. So thank you so much, Dr. Arokya Raj. I think this is a very well worked up case, and they have come to the final diagnosis of a LAC1 mutation. But if at all we were to see this child in a real life scenario, when the child came during the first admission, So the child came with fever, joint pain, joint swelling, and very high inflammatory markers. So do you think at that point in time you would consider the possibility of just say Kawasaki disease, considering this child is an infant, is coming with fever, raised inflammatory markers, and probably go ahead and give IVIG at that point in time?
Okay, so I think for the audience and in particular residents, I would like to open this case as if it has come to the OPD for the first time. And in that case, I don't want to be a very tunnel vision that it could be rheumatic disorder. If we look back, it's 10-month baby.
It's a 10-month baby after MMR vaccination has come with fever.
And if I could note the findings very clearly, there was pallor and there was some frontal bossing. So I would like to keep some differentials, and those who were alert yesterday in Dr. Priyanka's talk, I think few possibilities that sinister causes has to be ruled out, number one. Number two, given there is anemia, frontal bossing, there must be a nutritional cause, and I'm thinking in terms of celiac, and we know that a chunk of patients with celiac can also have arthritis. And then of course, given the short history, irritability, and high inflammatory markers, KD is again one of the possibility, and we know that a chunk of patients with KD can also have arthritis.
So absolutely. I think that's an important point, because some children with Kawasaki may have arthritis at presentation, although they tend to be older age at onset, usually when they have arthritis. And usually children with Kawasaki who have arthritis, it indicates that they may have IVIG refractoriness as well. So in this patient in the real life setting would have probably received IVIG and then declared himself later on. So, Dr. Oswal, how common is JIA actually in infancy? Would you have considered straight away the possibility of JIA in this child when it first presented at 10 months of age?
I think extremely rare to have a JIA in infantile age. In fact, many times is the diagnosis of exclusion. So you should think of many other conditions, inflammatory, non-inflammatory conditions, which can mimic like a JIA, and try to exclude from. So look at the clue from the history and clinical examination, especially if you have got a children with early onset, with additional family history, consanguinity, and atypical features like in this case he has. So always think of whether he has got a monogenic origin or single mutation, or whether they are genetic origin, non-inflammatory conditions you should think of.
Yeah, so JIA itself is a diagnosis of exclusion is what we say, but in infancy it's even more out of exclusion. So you have to rule out infections, underlying, sometimes even immunodeficiencies can manifest with fever and arthritis, malignancies can manifest in the same way. So it's very, very important under the age of 1 to be very sure about calling a child as having JIA. So this is something we published to say how you could approach joint pain in children irrespective of the age presenting to your OPD, and this was just recently published in Indian Pediatrics. We'll be happy to share it later on as well. So when should one, Dr. Narendra, suspect actually autoinflammatory diseases or monogenic forms of JIA in a child? So this child, obviously they have followed up over a period of time, and going by the pattern that the child had repeated fever and joint pain, they've probably thought of an autoinflammatory disease. When would you suspect in a busy OPD, say in whom you should order genetics or think of autoinflammatory diseases?
Okay. Fine. I think again autoinflammatory syndrome is a huge basket, and if we can recollect from yesterday's talk of Dr. Suri, I think the key points would be, one is early age of onset in this particular case. One, there is some association with vaccination. Often these kids have a flare of the autoinflammation triggered by any vaccination or viral trigger, and they will keep on mounting episodic fevers. The periodicity of the fever episodes, often triggered by some viral infection or vaccinations, is a clue, along with the raised inflammatory markers during that episode.
So absolutely, any child coming with recurrent unexplained episodes, fixed pattern with the interval between these episodes may not be fixed, but the pattern is usually quite predictable, and these can be triggered by specific stimuli, and that's what I would like to ask Dr. Anushka as well. In this child, particularly what Dr. Arokya Raj presented, do you think there was any correlation, because he said child received MMR vaccine and then the symptoms started?
Yeah, so in this case, actually, both the times when the arthritis flared, he had taken vaccination before that. So although there's no robust association between vaccination and arthritis, there are certain triggers, like even like infection, viral infections, we all know, but even things like exercise, menstruation, emotional stress can trigger a flare in these cases.
Yeah, and many a times these children actually, they present to pediatricians during a flare, they would receive antibiotics, And the natural course of illness is that the child will have a waxing and waning course and they go into remission. And this is indirectly attributed as response to antibiotics. So that is why when a child comes with recurrent fever, I think every episode it's very important to know the actual pattern of what other symptoms the child had apart from fever. And any personal experience, any of the panelists with such cases of LAC1 mutation or any monogenic form of JIA?
LAC1 mutation state, but then we have two children who presented between 6 months to 12 months with a fever and arthritis, were referred to us because they were resistant to DMARDs, and then now they are partially responding to biological drugs. And one of them has shown, the whole exome sequencing has shown macrophage migration inhibitory factor, which is having a susceptibility to systemic JI, and other has shown MVK mutation, but which is not fitting into clinical phenotype.
So absolutely, I think especially LAC1 mutation children can be very difficult to treat. They're very refractory to conventional treatment. I don't know how your patient is doing now, but most often they just don't respond to methotrexate. They usually have a very high burden of steroids. And what we've seen is they usually need a combination of some conventional DMARD or a biologic DMARD. So I have only one patient, but this child is on tocilizumab and tofacitinib. So that is the extent to which they can be refractory to treatment usually. And the other issue with these children, especially in the child that I was managing, is very refractory anemia. So despite extensive evaluation, we couldn't really find out why this child continued to be anemic, required multiple blood transfusions, even when the disease was actively controlled. And they have a lot of comorbidities associated because there's never a window for vaccination in these children because they're always on treatment. There's always a risk of secondary infections because they're on immunosuppressants and vaccination schedule has not been kept up with. So it's very challenging to manage these children. But one peculiarity about LAC1 is these children usually do not develop MAS. So if you are seeing a child with a systemic JIA-like phenotype coming with recurrent MAS, probably LAC1 is less likely in this particular child. And the scope of bone marrow transplant in these children, we still don't know. There is one case report to say that a child with LAC1 had undergone bone marrow transplant because that child developed leukemia. So for leukemia, the child was transplanted, but even the systemic symptoms and the joint symptoms went into remission.
So I have seen a patient with LAC1 mutation, and the onset was similar to this case, as in there was polyarticular involvement. There was no anemia at presentation, responded well to methotrexate, but after 2 years there was a flare. We started on adalimumab, and the child was okay for about 6 to 8 months, then developed anemia and refractory arthritis. We've now shifted to tofacitinib and she's doing relatively okay. So the anemia can come up later as well.
Absolutely.
And
so
another case is sometimes with anemia and polyarthritis. We've seen a case of Majid syndrome. Now I know that Majid is more of an osteomyelitis rather than an arthritis, but it's a proven pathogenic variant in the Elpin gene. So sometimes these
Sure. So I think that's where the role of genetics again comes up in evaluation of these children. So I think the key learning point from Dr. Arokya Raj's case of LAC1 mutation is if a child has arthritis in infancy, always look for masqueraders first. Rule out early onset of monogenic forms because these can be difficult to treat, or they may have very typical customized treatment plans that you can have. Genetics is the way forward, but please use with caution. Like yesterday they were saying, there are a lot of commercial labs and sometimes interpreting variants of unknown significance can be a challenge, and prenatal counseling is extremely important. So I think we'll wrap up this case, and I would like to call upon Dr. Ravali Pratima for the next case presentation.
Good morning, everyone. So mine is the case of systemic JIA with diffuse alveolar opacities. So we have a 6-year, 4-month-old girl child from Bangladesh presented with difficulty in breathing and fever of 3 days duration and cough of 14 days duration. So coming to the past history, at 3 years of age, child was diagnosed to have systemic JIA with macrophage activation at the onset, and she was treated with pulse methylprednisolone and cyclosporin. Over the period of next 1 year, she had 2 articular flares for which methotrexate, leflunomide was added and intra-articular steroid was given. Unfortunately, during the period of COVID, she was lost to follow-up and she was off medications for 4 months. After 4 months, she again presented with macrophage activation syndrome to us, and again she received a pulse dose of methylprednisolone. So considering early age of onset and 2 episodes of macrophage activation, tocilizumab was added along with a cotrimoxazole prophylaxis. So for the next 2 years, she was clinically well, but due to financial constraints, we had to shift from tocilizumab to tofacitinib. During this period, her cotrimoxazole prophylaxis was stopped. So currently at 6 years 4 months, she presented to us with fever, shortness of breath and cough. To note, after receiving 2 months of tofacitinib, parents have stopped tofacitinib for unknown reasons. So on examination, she had grade 4 clubbing, bilateral crepitations and chest retractions. Chest X-ray revealed bilateral opacities and echocardiogram revealed pulmonary hypertension. Her bowel culture showed pneumocystis jirovecii growth, hence she received cotrimoxazole with a stress dose of hydrocortisone and respiratory support. And this is her HRCT chest. So this shows multiple patchy areas of consolidation with ground glass opacities, atelectasis and calcified granulomas in bilateral upper and left lower lobe. Likely an infective etiology and organized pneumonia. So after the admission, initial 6 days, she became afebrile and she was shifted from HHFNC to the room air, and she was maintaining with low oxygen support. From day 6 to day 9 of admission, she again had a macrophage activation syndrome and we had to shift to pulse methylprednisolone. From day 10 to day 20, the initial mass has resolved and she was well on minimal oxygen requirement. So her PFT was done, that showed a restrictive lung pattern. So we had shifted to the oral steroids and later tofacitinib was added in view of SJIA ILD. From day 21 to 23, she again had an episode of mass, and this time we started pulse methylprednisolone as well, but she succumbed to death on day 23. So in the literature search, and yesterday we've seen Dr. Balu Atreya's oration that SJIA ILD is an entity, and apart from ILD we have pulmonary alveolar proteinosis and pulmonary hypertension as well. There is no guideline as such like which drug would be ideal to treat these patients, but the literature says IVIG, MMF and tofacitinib can be used. So the DRESS versus the effect of interleukin blockade, the argument is still there, the debate is still going on.
Yeah, thank you so much, Ravali. So I think it was quite a challenging case that they've had, and I've just summarized for the sake of simplicity for the audience to understand. So we have a 6.5-year-old girl who presented with systemic JIA and recurrent MAS from the age of 3. She was on tocilizumab for 2 years, between 4 to 6 years of age, and they have noted clubbing in a span of 4 months. So whether it was not picked up previously or the child really progressed that fast is something we'll need to see. Interim PFT or echo results probably were not available. And this child on the CT, actually having reviewed it with our radiologist, this child has predominant acute infectious changes rather than chronic ILD changes on the CT scan. And probably the acute presentation we felt is probably due to an infection rather than the underlying CLD. Probably the CLD predisposed her to developing pneumocystis jirovecii in combination with the fact that she was on immunosuppressants. And this time the child probably went into macrophage activation because of an infection which is pneumocystis jirovecii. There was transient improvement, then the child had recurrence of MAS and the child died eventually. So the question to our panelists are, so in this case, this child has had systemic JIA with recurrent MAS right from the age of 2. Would you have considered doing genetics at some point in time for probably underlying primary HLH or another autoinflammatory disease?
Yeah, so systemic JIA, although it does peak between 1 to 5 years of age, and this child has started at 3 years. So yes, it's prudent to think that it's SJIA and MAS, but when a child presents with recurrent MAS at an early onset, you have to rule out certain genetic causes. So primary HLH is one, so familial HLH because of mutations in the genes that are involved in the degranulation and the cytolytic pathway like perforin, etc. There are also primary HLHs that are associated with hypopigmentation. So if a child has some form of albinism with HLH, then that can raise your antenna to things like Griscelli syndrome, Chediak-Higashi, Hermansky-Pudlak. There are also genetic conditions which would predispose to EBV infection, so EBV susceptibility and hence an HLH. So that would include X-linked lymphoproliferative disorders or XIAP, etc. So when it is an early onset and such a recurrent mass, it's good to get this out of your way because the treatment would differ in both cases. So
yeah, and I think also this child subsequently has had more of systemic flares rather than articular flares. So that was later on systemic, sure. So, and screening with pulmonary function tests in children with systemic JIA, it's become a very relevant topic now and a very important area which we need to look into. How often would you do it, Dr. Narendra, in other children with systemic JIA?
So, I agree that it's a relevant topic, but as you have shared that around, it's not that common in systemic GIA cohort if you look at. It's only chunk, 1 to 2% of patients will have this. So the message is we should not routinely screen all kids with systemic GIA for PFT. That's message number 1. But then who are these 1 to 2%? So the possibilities in whom we are likely to develop this ILD is probably early age of onset, number 1. Number 2 is who is having recurrent episodes of mass, and there is an association of HLA-DRB115, and in those centers where you can get it done, probably if that is positive, that makes a case for an early screening, and maybe every 6 monthly is fine enough.
Yeah, and even children who have very high inflammatory markers, children who have very high inflammatory markers or who are going into recurrent MAS, they are also at a higher risk of developing lung disease. Probably it just reflects the degree of inflammatory activity that these children have, but it would probably be prudent to keep a low threshold is what I think, because it has great treatment implications in these children. And what about antimicrobial prophylaxis? So would you start all children on antimicrobial prophylaxis if they are on any DMARD?
I think those who are predisposed to or those who are on immunosuppression, and especially those who have underlying lung damage, definitely they are at risk of having a PCP pneumonia, like in HIV positive patients. So here, if they are on the higher dose of corticosteroid, then definitely you should think of starting a PCP prophylaxis.
So again, there are no fixed guidelines to say in whom we should give Septran prophylaxis when they are on immunosuppression, and there are no recommendations in pediatrics per se. But all I could find is 2022 EULA recommendation in adults, which says that anyone who is on glucocorticoids at a high dose, and high dose they've described as 15 to 30 milligrams of steroids per day, in combination with any immunosuppressant, they have said it might be prudent to consider the use of prophylaxis with cotrimoxazole. So this child, I think, was on Septran prophylaxis while the child was on tocilizumab, but when they were lost to follow-up, when they were on tofacitinib, we don't know if the child was actually taking Septran or not. In this child, recurrence of MAS, what are your thoughts on it? Is it due to lack of maintenance therapy, disease flare, or did the child actually have a new infection that pushed the child into developing MAS?
So in this case, we see that the child was lost to follow-up after you started on tofacitinib. So yes, there was lack of therapy at that time, but the problem is that along with lack of therapy, they'd also in all probability stopped their prophylaxis. There was a proven pneumocystis carinii infection, and as we all know, it has a very high mortality rate, especially in rheumatic diseases who are on immunosuppression. It is around 30 to 40%. So I feel that in this case, it was the infection that triggered the mass, and I feel that she finally succumbed mainly because of the infection.
Absolutely. And I think the choice of tofacitinib in the face of MAS, I know that the reason for starting tofa in this child was probably underlying interstitial lung disease, but having reviewed the CT scan, ILD didn't seem to be a major concern in this child as much as the acute infection was. So what are your thoughts on the choice of tofacitinib in the acute setting over here?
I think given the best available evidence as on date, I would refrain to use tofacitinib in setting of mass, though there is some evidence of baricitinib in cytokine storm syndrome related to COVID, but I'm not sure about high quality evidence for tofacitinib in mass. That's number 1. But another instant thought that is coming to my mind is probably you might have considered a low dose of etoposide in this case.
Any thoughts?
Yes, agreed. I think we should have considered etoposide or cyclosporin in this case.
Or even probably IVIG would have helped to some extent in the face of an infection. The issue probably they faced was the fact that there was some concern regarding underlying ILD, and child had grade 4 clubbing. So that is something which was challenging, and we know it's very difficult to manage these children once they develop an infection like pneumocystis jirovecii. So this is an absolutely challenging case, and I think eventually, do you want to add something, Ravali, about the management, what you all eventually did with the child?
We actually went ahead with the genetics, but by the time the report has come, child has passed away. So there was a mutation, heterozygous mutation with a variant of unknown significance of PI3K-R1 gene. So this was associated with ILD in few cases and also T cell defect in few cases. While our child had a pneumocystis jirovecii pneumonia, there were no other signs of early infection or recurrent infection, and probably we could have done an immunological workup as well in this child.
Sure, thank you so much. So I think we'll wrap up this case discussion, and the only thing also would be to say that we need to be more aggressive probably in looking for clubbing in these children, because in a busy OPD it's very easy to forget and miss out on this finding. So I think we have 2 minutes, we'll just quickly go through the last case. So this is a 15-year-old girl who presented to us in 2020 with pain and restricted movement in the left hip. She had morning stiffness, elevated inflammatory markers, HLA-B27 was negative, and imaging showed mild subchondral edema of the femoral head, and she also had some edema at the origin of the right gluteus maximus. She was started on sulfasalazine, which the family stopped by themselves subsequently. And in August 2020, she had a flare of symptoms in her lower back and her left hip. ESR was again quite high, and MRI of the lower back showed active bilateral sacroiliitis with erosions. She was restarted on sulfasalazine, this time along with adalimumab, which she continued for a period of a year. But even during that period of time, this girl continued to have pain episodes in her lower back, and her ESR kept shuttling between 15 to 35. In June 2021, while she was on adalimumab and sulfasalazine, she again had a flare of symptoms in her lower back with pain. ESR was 75, an MRI that was repeated again showed active bilateral sacroiliitis. So this time we were stuck because she was already on adalimumab and sulfasalazine, with which she had flared. So we decided to switch between TNFs, and we chose etanercept over infliximab because it didn't require regular hospitalization, and we added in methotrexate at that point. June 2021 onwards, we've had multiple attempts to bring down her drug load that she was on, and whenever we would try to stop methotrexate, this girl would have recurrence of pain in her lower back, ESR would go up again, and she was continued on triple therapy. So just recently in October again, I happened to see her, and she's come back again with pain in her right knee with morning stiffness, lower back pain again once or twice a week, and ESR has again shot up to 64. So question to our panelists, how would you classify this child? Because I know there are a lot of general pediatricians today. What form of arthritis would you classify her as?
So this child at onset came with hip arthritis, and she also went on to have inflammatory back pain. She's a 15-year-old girl. When you look at it on the whole, it seems like an enthesitis-related arthritis or a juvenile spondyloarthropathy. But if we strictly stick to the ILR criteria, what it says is a child less than 16 years of age, so yes, that fits. Arthritis and enthesitis of more than 6 weeks duration. So this child did not have enthesitis per se at onset, but she had arthritis, so yes. And any two of the following. So sacroiliac tenderness or inflammatory back pain was present. She was not HLA-B27 positive. She was a girl, so not boy more than 6 years of age. There was no history of anterior uveitis, and there is no family history in this child. So by the ILR classification, she would fit into an undifferentiated JIA. But it's very clear that she does fit into the spondyloarthropathy spectrum. So in fact, that is why there's a lot of debate on the classification of JIA, and a lot of attempts are being made to revise it. And Printo has come up with a new classification wherein they call it juvenile enthesitis or spondylitis related arthritis. And here they include imaging as in radiographic or MRI findings of sacroiliitis. So if we apply those criteria, this child would fit in better.
So on the MRI, she did have edema of the origin of the gluteus maximus muscle, so if that sometimes can be considered as enthesitis. Now the whole question is, in the first visit, would you have imaged her lower back, the SIJ, to look for arthritis?
The back pain, which includes significant morning stiffness and restriction, or maybe a Schauber's positive, that will make an indication for that.
Yeah. So typically in the first 6 months, usually they have peripheral arthritis, but over the next 5 years, eventually more than 90% of them develop sacroiliitis. And I think what you need to look for is inflammatory back pain. Sometimes this can be extremely difficult to elicit in an OPD. If a child has lower back pain that starts insidiously, improves with exercise, and lasts for more than 30 minutes in the morning, that is probably suggestive of inflammatory back pain. And the gold standard is MRI of the lower back or the SIJ without contrast. And these are the characteristic findings where you'll see bone marrow edema within the sacrum or the adjacent ileum. So how would you treat these children, sulfasalazine versus methotrexate? What are your thoughts on initial management?
MAD should be sulfasalazine, because majority of the studies has been done by using sulfasalazine. And the studies on methotrexate are sparse in ERA. And the other advantage of sulfasalazine is basically because many of these children has got a boil wall inflammation, and the sulfasalazine is useful in controlling the boil wall inflammation also.
Sure. And what they have gone on to say is that if a child has refractory enthesitis on sulfasalazine, keep a low threshold to starting anti-TNF, even if it's just one enthesial joint that is inflamed, because it can be extremely painful and limiting daily activities for the child. And in this child, would you consider JAK inhibitors now at this point in time?
Literature, I would go ahead with TOFA in this girl.
Absolutely. So I think this would be the way ahead for this girl. And I think with this, we'll wrap up the panel discussion. And thank you so much to all my panelists and the audience for listening. Thank you.
Thank you, Dr. Chandrika, Dr. Oswal, Dr. Bagra, and Dr. Anushka for such an wonderful session. You have highlighted all the points of chronic arthritis and how it is very difficult to manage, and how will point on to work out early identification of the disease and the look at the points of management. So I thank all the panelists and moderator for giving such message, and thank you all.
We have exceeded time, so we have got no time for question hour session. So the session we are winding up. Thank you everybody for the listening, and for the panelists and the moderator to deliver such a nice and excellent session. Thank you.
Thank you everyone, all delegates and faculties and presenters.